Here, and you don't have that arc, you could, and something happens to that artery, you could potentially lose blood supply to that half of the hand.
But you guys will see that before
Exactly.
you.
So there is fortunately, a very easy little test we can do, and we can do it the same day that we, go over your MRI, where it's painless. We just put an oxygen sensor in, I take a look with ultrasound. It takes about 10 or 15 minutes, and we can tell whether you have that arch or not.
Okay.
If you have the arch, which, like I said, at least 99% of the population does, then I would leave it entirely up to you whether you want to go in through the wrist. As I say, most people go through the wrist, but whatever you want to do. If you don't have the arch, then I don't think it's safe to offer it, so then we would only go in through the leg. It doesn't matter whether we go in through the wrist or the leg, the risks are the same. So one of the risks is infection. Anytime you make a hole anywhere in the body, even tiny little holes like we're going to make, and they're really small. If we go in through the wrist, everything's going to be done through something about the size of this pen tip. If we go in through the leg, it would be the rest of the pen part. So even the bigger thing is still pretty small. Ooh. So, but there's always a risk of infection. We give you antibiotics. We do everything under sterile technique, which minimizes the risk. There's a risk, too, that down the line, weeks or even months after the procedure, you can have little pieces of the fibroid break off as they're dying and come out, like in your monthly period or other times. And actually, that's fine. That's great. We're getting rid of it. It's going away. Good. But once in a while, that one of those little pieces can get stuck on the way down, and that can become infected. If that happens, then you got to go to the hospital and they've got to pull it out.
How would I know?
You'll know because it'll be not only intensely painful, but you'll get very
stank.
You'll get a very foul-smelling odor. You'll get fevers and chills. We're going to be in touch with you all the time.
Every day.
We're going to be calling. It'll probably be Robin, actually.
I don't even care. No, I'm tired of this.
Our risk for bleeding is far less than any surgical procedure because everything we do is so small, but it is a risk. Also, along those lines, I think our risk for infection is far lower than any surgical procedure, but it is a risk. There's a risk of bad reactions to medications. We talked a little bit about the contrast dye. The other thing that can happen with the contrast dye is that occasionally people have an allergy to it. If they do, it's usually some itching or hives or something like that, but very rarely it can progress to a very severe, life-threatening allergic reaction.
How do I know if I'm allergic?
You probably don't. So you've never had it before, so you wouldn't know that. One of the things that we do is I use a medicine right before the procedure called Benadryl. You may have seen it over the counter.
Yeah.
We use an IV, sort of a stronger form of it, which is I use it actually because it helps us with the procedure, but one of its really nice side effects, it also will make you drowsy, which is nice. Mm-hmm. One of its other really nice side effects is it significantly reduces the risks of having that kind of reaction. In fact, our patients that we know have that reaction to, we give them that medicine ahead of time. So we'd be giving you that medicine, either way. It helps us out, like I said, for the procedure anyway. The only other risk that I like to talk about is damage to any of the structures. So theoretically, we talked a little bit about the hand. There can be like a bruise or some damage down here if we go in the leg or even here. But one of the things I like to focus on is what we call non-target embolization. So when we're trying to cut off the blood supply, that's called embolization. If you cut off the blood supply to something, it's called embolization.
Okay.
So we're trying to embolize the fibroids, the uterine fibroid embolization. We want to cut off their blood supply. So occasionally, when we're releasing the tiny little particles and we're watching where they're going under X-ray guidance, the blood supply can carry them someplace that we don't want them to go.
No.
So we watch this in real time, and obviously, if we see that, we stop right away.
Could it happen?
It could happen theoretically anywhere in your body and cause problems for anywhere.
After the procedure or anything?
No. Once they're in, that's it. It's sort of almost like cement.
They don't move.
It's not going anywhere. It's going to cause that whole system to clot off, and it's not going anywhere. The only way to take them out would be to have the surgeon remove it.
Okay.
But during the procedure, and it could cause problems theoretically anywhere in the body. The way your anatomy is, the most likely place that they would go if they're going to go someplace we don't want them to would be to your ovaries. Now, at your age, if that happens, honestly, the most likely thing that would happen would be nothing. However, it is possible that it could make it that you go into menopause earlier than you normally would, we don't know when you're going to go into menopause, so it's a little hard to say. And the other thing it could do is it could make it that you're not able to have children again. Now, I know that's an issue for you. I would say it's not very likely, but I just want to be really clear that I can't guarantee that you'll be able to have kids after this procedure. I think it's very likely that it should not cause a problem.
People been...
We have, yes, absolutely. There are patients who have children with no problem afterwards, but I just, I would be lying if I told you, 100% guaranteed you'll have kids afterwards. I think that there's, every chance that you will be able to. And especially for somebody like you, knowing that you want to have kids, I tend to be a little conservative in the way I treat anyway. But I think for someone like you, I tend to be even more conservative, meaning, I'd rather, given two options, I'd rather undertreat the fibroids a little bit than overtreat them and potentially cause problems for you having kids down the line. And if say your symptoms only get, 80% better, well, that may be enough that you don't need anything else done and you're still able to have kids. But if they only get 30% better, then, over time, we could you can always go back in if we have to. Not that I would want to do that, but I'd rather have to go back in and treat them a little more than, because like I said, you can't take the particles out. So I'd rather sort of undertreat it if I had to go one way or the other. And I tend to do that. Again, we're watching all of this in real time, so if we see those particles going someplace we don't want them to go, we stop right away.
And if you had to stop, what do you?
So usually what we do is we can sort of redirect where we are and continue with the procedure, but try to get the particles in a blood vessel that aren't causing, aren't going to places we don't want them to go. In worst case scenario, we'd have to just stop if we can't get that.
Well, I guess what I'm asking is, if you had to stop, which that's fine. Would you be able to keep those particles from going to my ovaries or something that I need?
If I saw the first time I would see them going to your ovaries, I would first of all, I would immediately stop injecting them, and then we would try to redirect where we were, and so that they weren't going there. So you'll stop, you'll try to redirect it. The ones that went wherever, they're already there.
So what are my chances with it?
Again, your age, you're for my population, you're really young. So you're what we call the ovarian reserve is high, meaning your ovaries are young and have a good chance of bouncing back if anything should happen. A better chance than somebody who's 45. Okay. Not that 45 is old, especially where I'm sitting from.
It's not.
But
I'm 31, so I'm
like a patient who's 45, who's sort of more of our typical age group. They have a much lower chance of those ovaries sort of bouncing back normally.
Okay.
But in any case, if I see anything like that, I would stop.
Okay.
So that's pretty much the procedure in a nutshell. We have it here. It's an outpatient procedure. You go home the same day. Like I said, you need that ride. We'll give you food afterwards. You'll have your own private room and your own private nurse. In fact, probably her. You usually end up being her. And you can have your family or whomever come back and be with you or not. It's entirely up to you. You can watch TV. You can read. Most of the time, you'll probably want to just rest after the procedure.
How long after the procedure do you have to?
So it's usually I tend to keep people a little longer than they want to stay. Honestly, that's usually people are knocking on my door saying I want to go home. But
less long.
I would say a couple hours.
But I still get to go home though that day.
Of course you're gonna go home. Yeah, we're not keeping it. I tend to be a little more on the careful side, so. Yeah, I will say this. If we go in through the leg for whatever reason, that's going to add 2 hours to anything because we have to have you lie real flat,
totally flat
for 2 hours. So
I love Um,
Oh, you've got stairs?
3 flights of stairs.
Okay. I mean, it's doable.
Okay.
You'll have to be real careful. I mean, no, like...
Right.
Like this. If we're going through the wrist, it won't be an issue at all.
I'm assuming I can't lift
I
really
would
with that
yeah,
arm.
the only thing I would stay away from, you can do your cell phone, you can do whatever you want.
Typing.
You can type. I would say no heavy weights for at least a week with that
Keep your
hand.
purse off that
Yeah,
way.
because
Yeah.
this thing is heavy.
Right. We always go in through the left. Are you left-handed or?
No, I'm right-handed,
Okay.
but yeah, I tend to sometimes.
Yeah, I'm sure you're carrying
Carry
things.
stuff
So
like this.
for that first week until we see you back, no, no weights, nothing like that. But with your right hand, you can do whatever, and you can text and type and whatever else you need to do. So yeah. Any questions?
No, I think you answered.
Okay. So why don't we do this? Let me get you a prescription to get an MRI.
Okay.
I would say the most important thing with the MRI is to make sure wherever you get it done that it's on your insurance.
Right. How do? I guess you were
Eileen
saying.
can check for you probably
I
at
told
the
her
front.
about it.
Okay.
Now, you told her about NSI?
Yeah.
Yeah, so there's this place NSI. We don't have any relationship with them. We're not financially tied to them in any way. But I send them a lot of business because
they're close by.
here. But they have them. They're all over
another
town.
one in Melbourne.
Is there Melbourne? There are a bunch of them. But this one's right here, and I know.
Do you have to have an appointment to go to them?
You can walk over there and see. Sometimes they'll
But
take you on
Eileen,
as needed
Eileen
basis.
can usually get you an appointment
Okay.
too. But they, I know they're radiologists because I talk to them because we send them a lot of patients, and they do really nice MRIs and they do things exactly sort of how I like them done. So I like it. That said, an MRI is kind of an MRI. So if they're not on your insurance, don't go there.
Right.
It's
right.
not worth it because it means the difference of hundreds of dollars, and it's simply not worth it. So she can check to see if you're on insurance. If all things are equal and they're on your insurance, and it's not too inconvenient for you in terms of location, then I would recommend that.
Okay.
So. All right, so let me get you the prescription. Actually, I'll give it to Robin, and she'll give it to you. So what we'll do is, once you get the MRI, wherever you get it from, I'll look at the images and look at the report, and then we can make an appointment for you to come back in. We can go over the MRI, and then if you want to proceed at the same time, we can do that little ultrasound test to see if we can get in through your wrist.
Well, I was gonna tell you I want to proceed.
Okay.
So, okay.
Do take our card, and if you have any questions that come up in the meantime, give me a call, and I'll get back to you.
I will.
All right?
Thank you so
You're
much.
very
I just
welcome.
heard what the doctor said. It was a lot of information. A lot of information that was new to me. I already knew this was going to be an emotional journey, so I figured I was probably going to cry just because of the simple fact that I'm not going to have to deal with it anymore. That's just a blessing in itself. I'm definitely going to get the procedure done, and just stay prayed up. You guys pray for me. Yeah, I guess we'll find out. I'm going to try to get the MRI done today, and then get everything on the road, on a go. My eyebrows are a mess. I haven't done anything to them. But yeah, I'm not going to keep talking. So I'll take you guys hopefully to the MRI with me. Not inside, obviously, but me going to the MRI. If you guys have any questions, you already know what to do. Comment down below. Bye.